Thank you. So this is my project titled Distal Internal Carotid Artery Changes in Persons with and Without Chronic Inflammatory Conditions. Why is this not advancing? Okay. So since we're talking about blood vessels, I thought it could be helpful to do a quick little refresh on our blood vessels. So they are composed of three layers, and I'm going to turn on my laser pointer. So you have the external adventitia layer, the muscular media layer, and the innermost intima layer, and then the actual lumen of the blood vessel. And then in this image, we also see vasa vasorum, which are small blood vessels that feed the tissue of larger blood vessels in our body. And then I'm also going to be referencing throughout this presentation the concept of perivascular adipose tissue, and that would just be fatty tissue surrounding the blood vessel. So as we know, damage happens over time to our blood vessels. Some damage is associated with aging, but most damage is associated with metabolic disease and the induced states of chronic inflammation that come with those. Namely, what was important to me were diagnoses of hypertension, hyperlipidemia, and diabetes. So how does damage occur to our blood vessels? Erica elucidated this a little bit, but I'll expand on it. So endothelial damage of the intimal layer occurs through a variety of mechanisms. In a person with high blood pressure, it could be from the increased mechanical pressure or turbulent blood flow. In a person that has hyperglycemia, it could be the damaging reactive oxygen species from that hyperglycemic state. Either way, some sort of damage has occurred to those endothelial cells, and it allows the deposition of lipid particles in our blood within that intima. So the deposition of foreign materials within the intima lends to the recruitment of inflammatory cells, especially in this case, M1 macrophages, which are pro-inflammatory. So these M1 macrophages attempt to digest the lipid material, become lipid-filled foam cells, which are at risk of cell death. And clusters of these foam cells are the basis for what we call subintimal thickening or plaque formation. Eventually, those foam cells will die, and that necrotic foam cell tissue releases factors that allow for microscopic calcium deposits, as Erica said earlier. So just to summarize what types of vessel damage occur and what are we talking about today, subintimal thickening or plaque formation, calcium deposits, recruitment of inflammatory cells, and then what I hadn't discussed yet was the increased incidence of the vasa vasorum, the small blood vessels. And then I included just a little image here of a healthy blood vessel versus a blood vessel with plaque formation, damaged endothelium, and then we can already see here that the lumen size would be reduced in this blood vessel. So why are these things damaging? Subintimal thickening is damaging because it narrows the blood vessel lumen, contributes to poor blood flow. It also lends to more turbulent blood flow and endothelial damage. Calcifications are damaging because they attract inflammatory cells to the site. And these calcifications are very small and they're not organized. So these deposits are not stable and actually lend to instability of the forming plaque and its likelihood of rupture. And then, releasing an embolus in the blood system. Inflammatory cells can certainly be damaging. These M1 macrophages release a lot of interleukin-1 beta, which attracts a wide variety of additional inflammatory cells to the area. And then as we've established, those M1 macrophages, as they die, get necrotic, they form the microcalcification deposits. And then the increased incidence of vasa vasorum has found is strongly associated with presence of heavier atherosclerotic plaque burden, lumen narrowing, and calcifications. So there's a lot of overlap in how these damage patterns occur and sort of compound on one another. There's an additional type of blood vessel damage that's being researched lately, and that is of the perivascular adipose tissue. So it was originally thought to just sort of be insulative and protective to our blood vessel. However, recent research has shown that the perivascular adipose tissue is actually a very active endocrine organ. It is secreting things, it is responding to things. In fact, one study found basically a liver PVAT connection, like a talking connection. So that's very interesting. So in a healthy person without metabolic disease, that perivascular tissue should be healthy brown fat phenotype, which secretes things that lend to vasodilation and healthy blood vessels. In persons with the metabolic diseases, the PVAT will change to unhealthy white fat phenotype, which secretes pro-inflammatory adipokines, attracts more immune cells, and promotes vascular endothelial proliferation that leads to plaque formation. So one of the questions I then had was, is PVAT damaging intracranial blood vessels? So inherently, I apologize, I'm getting over a little thing from this weekend. So perivascular adipose is not thought to exist in the intracranial space, but vasovascular was also thought not to exist intracranially. However, in unhealthy persons with metabolic disease, there are many studies that have found vasovascular expanding through the dura mater into the intracranial space. So I was just curious if perivascular adipose tissue could be doing the same thing. So that was one of the goals of the study. The other goals would be simply to look for presence or absence of calcifications, subintimal thickening, inflammatory cells, and vasovascular in these two populations, cohort without metabolic disease and a cohort with metabolic disease. And then another question I had was, does the vasovascular extend more distally than currently known? So several studies have found that it does extend into the intracranial space, but they've all found vasovascular to be growing pretty proximally within the intracranial space. So I was curious, yes, if it grows more distally, and what kind of inflammatory cells might be present as well. So to look at all of these things, I utilize the embalmed cadavers that we have available through our student dissection program here at KCU. I also use their de-identified data, such as sex, age, and available medical history to make my groups. So I had a control group of 10 donors without histories of chronic inflammatory conditions, and an experimental group with 10 donors that do have relevant metabolic disease history. And from those, I took small cross sections of their distal internal carotid artery right before it bifurcates into anterior and middle cerebral arteries. So, and just to note, the donor brains were removed through routine first-year medical student dissection via cuts to the vasculature and the spinal cord. So that did lend to some variability in how much internal carotid I had available for sampling. The collected samples underwent H&E staining through our relationship with University of Missouri One Health Biorepository, and we got those stain slides back, and our lovely pathologist, Dr. Hamden, helped me look at those. And she originally looked at them without knowledge of whether a specimen was assigned to the experimental group or the control group to prevent any sort of bias against what she might have been seeing. So as far as results, first, I think it's important to discuss the metrics that we wound up having between the two different groups. So we see here, average ages weren't terribly different. Distribution of males versus female donors, not that different. Average weight, average BMI. Luckily these groups ended up being pretty similar as far as metrics go. Again, as I've said, the experimental group all had history of metabolic disease, and then 2 of the 10 additionally had history of cancer. And then just the way the control groups worked out, 8 of those 10 donors had histories of cancer. So looking at slides, only 19 total slides were usable. So that was 2 slides per donor, 1 for the right and 1 for the left section of the internal carotid that we took. So my first question was answered pretty quickly. Did perivascular adipose tissue extend into the intracranial space? That was a resounding no. As far as subintimal thickening, we had a fair amount in the experimental group, as well as calcifications, which would be expected in persons with metabolic disease. We did have some subintimal thickening and calcifications in the control group. That can happen with aging, so that wasn't that unexpected. Then we got to presence of vasovassorum. So in 16 of the 19 samples from the experimental group, we found significant vasovassorum growth pretty distally, as well as a fair amount in the control group, which is interesting. And then presence of inflammatory cells. We had a fair amount in both groups that had inflammatory cells, and we saw a wide variety of lymphocytes, macrophages, and neutrophils among both groups. And so I wanted to then just provide you with some examples of what we were seeing on these H&E slides. So this is a sample of very large vasovassorum here from a donor in our control group, or no, I'm sorry, the experimental group. So she was a 90-year-old female with relevant history of coronary artery disease and atherosclerotic vessel disease. You can see some plaque here. So that's kind of what we were looking for. So then we get to some examples from our control group. So this was an 82-year-old female who didn't really have cancer or any metabolic disease, but we can clearly see here vasovassorum growth with a lot of red blood cells in this blood vessel. Another from the control group, a 71-year-old female, history of metastatic lung cancer, double mastectomy. And we see vasovassorum here with red blood cells. And then another example from our control group, 72-year-old female, no metabolic disease, but a history of ovarian cancer. And we had several on the sample of these lumens with some red blood cells in them. So as I pointed out, the metrics of the experimental and control groups were pretty similar. Perivascular adipose tissue does not seem to grow in the intracranial space, even in persons with metabolic disease. We found subintimal thickening and calcifications in both groups, definitely more so in the experimental group. This follows known data and was expected. Vasovassorum were clearly noted in distal portions of the intracranial space in both groups. This does not follow known data whether or not they had metabolic disease. Only proximal growth has been well documented, so that was an interesting finding. And then vasovassorum and inflammatory cells were highly present in the experimental group and unexpectedly present in the control group as well. I went back and did some more research just to make sure I didn't miss something, but I really couldn't find any history of cancer being associated with growth of vasovassorum. I did want to note when I was going back through and doing a little more research, I did find a study that found vasovascular growth was stimulated when a person was getting radiation treatment for cancer, but it was specifically localized to the area where the person was getting radiation. So none of these donors had head or neck cancer, no brain cancer. I also personally collected all of these tissue samples, and I did not observe any gross presence of brain anomaly or cancer or tumor or anything like that. So yeah, just unexpected, very interesting to find vas vasorum and inflammatory cells that far away from sites of cancer. So next steps in conclusion, obviously a large limitation of this study was the small sample size, which didn't really give me the ability to draw statistically significant results. I can just say these were interesting findings. So I have then a question, I guess, coming up is for me is, does cancer cause more systemic damage and inflammation than we even realize today? That kind of makes me wonder about things like VEGF signaling around cancer tumors, spurring blood vessel growth. Is that somehow traveling systemically and causing blood vessel growth in places far away from the tumor? So I would love to see future studies intentionally include donors with histories of cancer, larger sample sizes, maybe look at several sections of intracranial vessels, different vessels. So my conclusion is that we have so much more to learn about vascular changes in the intracranial space. And I would just like to say thank you to all of the body donors and their families. That their gift is so generous, and it definitely makes all of our research possible. And thank you to Dr. Leo and Dr. Hamdan for all their help. And these are my resources. And these are my kitty cats and me hiking.